Hi, everyone. My name is Jamie Stutz, and I'm co-leader of the Cancer Prevention and Control Program, along with Dr. Raj Agarwal. We had a few technical glitches when we started the seminar series this month, so I'm going to do a quick introduction of Dr. Lisa Carter-Harris and her work before transitioning directly into her presentation that will be already in action or moving. Dr. Carter-Harris is a nurse practitioner and associate attending at the Memorial Sloan Kettering Cancer Center. She completed her graduate training as a doctorally prepared nurse at the University of Louisville before conducting a postdoctoral fellowship at Indiana University and taking her first faculty position at Indiana University, and then being recruited away to Memorial Sloan Kettering within the past couple of years. Dr. Carter-Harris is a leading behavioral scientist in the area of lung cancer screening implementation, shared decision-making, and lung cancer stigma. And we're very excited to have her here and share her research on facilitating implementation of lung cancer screening with a focus on generating interest and uptake and helping folks make informed choices about lung cancer screening. And so now I'll turn it over to Dr. Carter-Harris, whose presentation will be underway. Thank you.
If you build it, they will come. No. So just because you build something does not mean people are going to come for lung screening. This has been unfortunately and dismally true. Depending on what study you look at, 5 to 14% of people who are eligible for lung cancer screening have been screened in the US for the deadliest cancer. I'm talking to a cancer center, so I don't need to give you the statistics of lung cancer being the deadliest cancer. But the other thing that is striking is approximately 10% of people who are eligible for lung cancer screening have had a discussion with their clinician or even aware that lung cancer screening exists. It's one thing to choose not to do something because you've been informed about it, but it's another thing when you don't even know that there's an option that exists. So why is the patient perspective important? I kind of explained that in my intro. I tend to do that. I explain things before I get to the slide. So my apologies. And I don't have to give you any of this because I am actually talking to people at a cancer center. So I don't want to belabor the point. But just a little history for those that may not be so enveloped in the lung screening world like I am. A grade B recommendation was issued by the USPSTF on the very last day of 2013, December 31st. We kept waiting for it to come out and thought it wasn't, but they did. But then it took another year and 2 months for Medicare to decide they were going to cover it. There was a lot of back and forth with people who were for or against and really debating the merits, the scientific merit of lung cancer screening, but it was finally covered by Medicare. Interestingly, they threw in the caveat for the first time for reimbursement, you had to have a shared decision-making and counseling visit in order to be reimbursed for lung cancer screening, which is not something that is attached to other types of cancer screening. And then, we have, even though lung cancer screening recommendations are still relatively recent, you could argue that relatively recent because it's, been 8 years now, or almost 8 years, there's low uptake, and that's multifactorial. Lung cancer screening is influenced by multiple variables, not just at the individual level, but the clinician, the social, environmental, and healthcare system levels as well. And what influences someone to screen or not screen? We actually developed a conceptual model to understand lung cancer screening participation from the point of view of the person making that decision, the patient. And we combined the health belief model, which is a very old model. Of course, everybody knows that particular model, especially if you're a psychologist like Jamie Stutz is. that, you know, your things that influence it would be perceived benefits, perceived barriers, self-efficacy to complete the action, as well as someone's perceived risk. The precaution adoption model, process model is related because of that decision not to screen. And so the precaution adoption model was actually built on the trans-theoretical model, from someone being unaware and unengaged to going to making a decision and acting on a decision. But that one little caveat of having a stage where someone can thoughtfully think about the decision to screen for lung cancer and say, my decision is not to screen, is captured in the precaution adoption process model. But then with this particular type of cancer screening, there are other variables that are important for us to consider, like stigma and medical mistrust, cancer fatalism, lung cancer worry, lung cancer fear, that are more salient in this type of cancer screening than other types of cancer screening. If you think about it, lung cancer screening targets a population based upon their age and their smoking history. And smoking is stigmatized. It's a behavior and addiction that is stigmatized. When you compare that to breast and colorectal cancer screening, which is age and family history, and not as stigmatized as lung cancer screening. So what does the evidence tell us? Populations that are less likely to screen are minorities, underrepresented populations, uninsured, which makes total sense, lower income, and individuals who are, I did not catch that. It should not say former smokers. It should say individuals who used to smoke. We're very passionate about person first language and not further stigmatizing by not categorizing people by their behavior. So I will have to correct that slide. But individuals who used to smoke, and the reason that is because they've quit smoking, so they don't think their risk is the same. They think because they're no longer smoking, they don't have a risk for that. And people who are more likely to screen are individuals who currently smoke because they view their risk as being higher, people who have a family history of lung cancer and have experienced that, as well as individuals who have a heavy smoking history. Psychological variables that make them, that influence a person's decision to screen, perceived smoking related stigma, either things that they've actually experienced or things that they perceive to experience. They worry about being blamed for having smoked. And there's this, in some individuals, there's a perceived self-infliction of their history of smoking that they caused the cancer or the potential to develop cancer. Mistrust of healthcare clinicians and the healthcare system overall. There's a historical memory with some underrepresented groups. And I don't like to, when talking about African Americans, I don't necessarily like to fall back on the Tuskegee experiment, because that happened so long ago and there are still things that are happening in today's current environment in which African Americans and people from other underrepresented populations are experiencing egregious acts that would cause them to mistrust. Lung cancer fatalism, feeling like, lung cancer is equals death, not understanding that there are treatments that have evolved over the past decade if we can catch it earlier. And feeling like I'm going to die anyway, so there's nothing you can do. Fearing what a lung cancer diagnosis might mean, and then worrying about that, that decision. Well, although moderate levels of worry tend to make people screen, but once you hit a high level of worry, that's actually a negative reaction. So it's like pointing to the ostrich with their head in the sand. And then other variables we looked at that we thought might be important are social influence. If they have friends or family that have heard about it and talked to them about it, media exposure, had they heard anything about it, about lung cancer screening and newspaper ads or on the radio or if anybody listens to the radio anymore, or television. And then our knowledge levels and health beliefs. And embedded in the health beliefs is the cue to action, which is embedded in that clinician recommendation. Does the clinician even bring it up or not with screening eligible individuals? So we talked about the precaution adoption process model, and this just shows you the 7 stages. And you know, it's interesting when you look at these different categories, because I always think that someone who is unaware, they've never heard of it, or they're unengaged, they've kind of heard of it but haven't really thought about it, is very, very different than someone who's undecided. I actually think someone who's undecided is more thoughtful, because they've been given the information and they've really thought about, is this the right decision for them? So even though you would classify these 3 categories, as well as the decided not to act, into the non-screener category, they're very different than they all have their individual variables that make them interesting, I think, to study. Let's see. We talked about that. This is actually the full conceptual model that we published in, I think it's on Research and Nursing Theory and something in practice. And this is looking at both sides, including the shared decision-making process. But when we actually tested the model, we looked at the patient perspective and that patient interaction. So we didn't include interviewing the clinician in this particular study. And so the conceptual model pieces that we tested in the R15 are this particular slide. So we did a sequential explanatory mixed method study, which just means that we did a quantitative component first that informed our qualitative component second. And so we purposefully sampled 515 screening eligible participants using Facebook targeted advertisement to recruit nationally. And we had all geographic regions that were represented. And I really like the way that we did this, just because what we did was we used the survey results to inform who we wanted to talk to. So the bottom part of this slide, the table, is showing you the cells that we filled with the individuals that we did the in-depth interviews. And really, even though I guess it is a little bit complicated as far as the table, but essentially we were interested in talking to people who were convergent and divergent from the conceptual model. And I was most interested in talking to people who were divergent. So, and what I mean by that is everything in their survey responses said that they were a screener, but they decided not to screen, or everything in their survey said that they would not be a screener, but they did screen. And so we wanted to kind of hone in on those particular people, in addition to people who, you know, screened and said they would screen and did screen, and vice versa. But we wanted to see, with those people who were divergent from the model, if there were any variables that we might be missing. And we tailored our interview guides based upon the participants' specific survey responses. So, and I think I have a slide that actually shows that. But so if an individual was, scored high on stigma, high on fatalism, and high on fear, we would actually tailor our interview guide to bring back those survey responses into the interview and have them expand more on that. So this was I'm actually going to not spend a lot of time on the quantitative side, just simply because I really want to get to the qualitative side. But this was our demographics. The majority were female. Unfortunately, the majority were white, but we did have 10.3% African Americans. And you can also see that most were educated, either with a high school diploma or higher, and most were either married or divorced. Most were retired, but that made sense because of the age demographic that lung cancer screening guidelines were at the time. And these were the old guidelines, which were age 55 and up, 55 to 80. And individuals, most 62.9% were individuals who currently smoked, and they had about a 2-pack per day history. And as you can see, most individuals indicated they were unaware of lung screening out of this particular sample, but we did have individuals in the other buckets. So what we found with regard to our antecedents, the psychological variables, demographic variables, and others, the statistically significant part of that in lung screening participation was an inverse relationship with medical mistrust and a positive relationship with the clinician recommendation. We found that cancer fatalism, worry, fear, and a positive smoking history, as well as a positive clinician recommendation, was associated with the lung cancer screening health beliefs. And we found that between the lung cancer screening health beliefs, self-efficacy was predictive of screening participation. And this was our path analysis for looking at the statistically significant self-efficacy health belief variable, as well as screening behavior. So I wanted to get to the qualitative phase because it takes a while to go through, and I also know that there's want to allow time for questions or discussions. This quote, the answer is always in the entire story, not a piece of it. I tend to ask questions from a research perspective that lend themselves best to a mixed methods approach. I think when you're dealing with human beings, just surveying them or doing quantitative measurements of some sort are not the whole story. And really understanding the story involves actually talking to individuals about their experiences. So as I mentioned, we did in-depth interviews, and we did them with 50% of individuals who indicated they had been screened, and 50% of people who were unscreened. I talked about that before. And so this is a really busy slide, but this just explains to you how we defined favorable to screening and unfavorable to screening. We broke the variables out into psychological factors, which was stigma, mistrust, fatalism, worry, and fear, and then cognitive and health belief variables, which were knowledge, perceived risk, benefits, barriers, and self-efficacy. And then we classified them. They had to have cutoff scores on 3 of the 5 scales, either high or low, to be considered favorable to screening, unfavorable to screening, from both of those perspectives. And so that's how they fit into the buckets. And then we had a list where we coded them, and we took every 7th person in that list to try to recruit them into the qualitative component of the study. We developed for each person based upon their screening status, as well as their specific scores on the subscales, the interview guide. So for example, if a person had been screened for lung cancer, would be asked, like, you indicated on your survey that you had been screened for lung cancer. Could you tell me how you decided to be screened? And let them respond. And then if they had low score on medical mistrust, we would say, you indicated on your survey that you do not completely trust your healthcare providers. Could you tell me more about that? And then we would have different probes for the different answers and responses. And we got a lot of rich detail from individuals. We used classic content analysis to for all relevant data to the participants' reasons for deciding to be screened or not. And we divided these into text units. And then we labeled each text unit with a short code or phrase to capture its essence. And then we used a data display table to display these codes that could then be overlaid with the quantitative results. So for this smaller group, we had 40 individuals who were recruited into the qualitative component of the study, but unfortunately, one of our recordings did not record. So we only had data for 39 of those individuals. And as you can see, the majority were female, white, married or divorced, and a little less than half were actually individuals who currently smoked, and 21 of them were screeners. So we found that the decisions regarding participation in lung cancer screening kind of broke out into 5 themes or 5 buckets. People who had no intention to be screened whatsoever, people who had no deliberate consideration about screening, but they were open to considering it, deliberate consideration, but no definite decision to be screened, people who intended to be screened but hadn't actually gone through with it yet, and then individuals who had been screened. So in these buckets, we had a lot of interesting quotes, but I pulled out some that were most representative of individuals of these different themes. So people who said they had no intention to screen really described it as it's a waste of their time, not worth the time or effort. One individual said, I firmly believe that if he, referring to his physician, felt it was necessary, he would have recommended it, the lung scan. So that kind of supports what we know to be true, that the healthcare clinician's recommendation is really powerful. Not really understanding what screening is, that you are trying to find something early before you have any symptoms. Individuals would say things like, I don't have any symptoms or any reason to get a lung scan. Not really understanding what a CT could do. If I feel if a chest x-ray doesn't show it, what good is a CT? If you're going to get lung cancer, it's going to show up on a chest x-ray eventually. So not really understanding that, you want to catch something early before it shows up on chest x-ray. And then, concerning, one person said, my doctors told me it was unnecessary at this time. I mean, we're supposed to trust our doctors, and I'm not having any issues, so I'm trusting his word. He regularly listens to my lung and my heart, and I'm going by what he says, so what can I do? Which is really super scary, because you can't hear lung cancer when you use your stethoscope to listen to someone's lungs. So individuals who described that they were somewhat open to be screened but really had no deliberate consideration would say things like, I just never considered it. I've always been pretty healthy. I have other things to deal with, those time constraints. We had a 65-year-old woman who was currently smoking, claimed she would not shy away from being screened, but she never even knew about the lung scan until she joined our study. A 62-year-old woman who used to smoke said she didn't have a steady provider, but if she did, that might influence her decision to get screened. She said that, yes, screening's a possibility, because maybe if I was going to the same person all the time and I had it been recommended maybe more than one occasion, I might consider doing it. The third category, deliberate consideration, but no definitive, these undecided individuals. Things like, I thought about it many times and would absolutely want to scan if it was recommended by my physician. Another one, time and costs were deterrents to screening. Other participants wanted to be screened, but were reluctant to get screened because they feared the results. A 55-year-old Caucasian woman who used to smoke said, I'm gonna go to get a lung scan, but right now I haven't gone. Eventually I will go. I'm just trying to work up the courage. Other reasons were really common pressing health issues that took precedence over screening, and then not having a regular physician to order the scan. Those who intended to be screened but hadn't screened yet, for example, when the interviewer asked a 59-year-old Caucasian man who currently smoked how he decided not to have a lung scan, he responded, "It's not that I haven't decided not to do it, it's just that I haven't done it. I've actually decided to do it, I just haven't approached it yet." And then a 55-year-old African-American woman who formerly smoked said, "Yes, I have considered it, being that I do have COPD, and I have been a smoker for over 40 years. So yes, I plan on being screened as soon as possible." And then finally, individuals who had been screened, the most common reasons for screening were they were experiencing pulmonary problems, which really isn't screening, that's diagnostic, receiving a recommendation from a physician, and then valuing early detection of cancer. Individual that experienced pulmonary problems said, "I was screened because I do have stage 4 COPD, so of course they did a test for cancer." And then receiving a recommendation from a physician, my doctor suggested, "Of course, being a smoker," I said, "well, that's a good idea. I had no problems with it." And then the individual example of individual valuing early detection, they indicated that they had a lung scan because they wanted to stay on top of their health, felt early detection is best and wanted to catch the cancer early. You know, some of them compared the advisability of having a lung scan to that of other routine screening procedures, such as mammography or colonoscopy, indicating that they try to stay on on top of various health issues. So what does this information mean, and why the heck do we care? So the results were important for us because it supported which psychological variables were associated with screening health beliefs, and which direction of those associations extended our prior work by supporting which which variables were potentially modifiable intervention targets on which to tailor our decision support materials. As well as confirming the strength of those relationships. Bottom line, because the patient population targeted for lung cancer screening is based upon a predominantly stigmatized lifestyle, it's important that we think about how do we support our patients, and how do we support our clinicians in these critical lung cancer screening discussions. As I mentioned before, I think things need to be conceptually grounded to support both the inclusion of the different intervention components that we use to design decision support tools, health communication tools, as well as understanding what is driving behavior change in lung cancer screening. And then understanding this patient population more robustly has not only the potential to have positive implications for those that are considering lung screening, but also for tobacco treatment interventions for this high-risk patient population. We at MSK have a lot of research as well as clinical practice, what we preach, so to speak, in empathic communication. We believe that how you talk with individuals who currently smoke or formerly smoke affects their rapport that they develop with their clinician, as well as their patient outcomes, because of their willingness to engage with the healthcare system. And so we've been doing a lot of work around empathic communication for clinicians and how to best interact with our individuals who have a tobacco history, as well as how do we change the messaging around this type of cancer screening, and not just make it a smoker's cancer screening, and the fact that that implies there's a blame. Okay. Of course, no study's perfect. This particular study had limitations to generalizability. I always get the pushback when I recruit using Facebook or social media of generalizability. although I have done studies prior where we've recruited with traditional means and social media means and compared the population demographics of those we recruit, and they're very similar. Self-selection bias, of course, into a study, and racial diversity. We didn't, even though we had 10% African American, I would have liked it to have been much higher, as well as representative of others, other racial and ethnic backgrounds like Asians and Hispanic, etc. Let's see. This is my puppy, just for, to throw a cute thing in there. But the next steps in this journey, we were funded almost 3 years ago by NCI with an R01. It's a multi-level study to understand shared decision-making in lung cancer screening. And this is actually a descriptive study. We're building a multi-level analytic data set to examine the shared decision-making encounter about lung cancer screening to understand the active ingredients, so to speak, that lead to positive behavioral and positive decision outcomes. I'm an affiliate investigator at Kaiser Permanente, Washington in Seattle, and we're recruiting, we have a clinician side of the study and a patient side. So we've recruited 137 clinicians who are primary care clinicians, they're physicians, nurse practitioners, or physician assistants who see screening eligible individuals into the clinician side of our study, which they've completed a survey about their attitudes toward shared decision-making, attitudes toward lung cancer screening, barriers, all sorts of different components that we were interested in. And then on the patient side, our target sample is 550. We've recruited 360 thus far. We have a rapid ascertainment recruitment protocol. So KP Washington was kind of pioneering in this area several years ago when we wrote this study, in that they changed their EMR to document when an individual comes in for a visit and you have a shared decision-making conversation with them around lung cancer screening. The reason that was important was in other healthcare systems, the only way you could tell if someone had a shared decision-making visit is if they were referred to lung cancer screening. So you missed people who had this discussion, but made the decision not to screen. And so they didn't have an order for an LDCT for lung cancer screening. So we have a programmer, a wonderful programmer who wrote code, and it's run daily to identify these people who have met with, had a clinic visit and a documented shared decision-making visit about lung cancer screening in the past 24 hours. And then our survey team reaches out to the patients by phone to recruit them, enroll, and administer the surveys. And that's worked really well for us. This is another picture of my dog. I do have kids, but they're 19 and 20, so you don't get pictures of them, you get pictures of the 6-month-old puppy. The next steps in this journey, in this particular study, these were our aims. Essentially, we were looking at key components around shared decision-making process that predict patient-perceived lung cancer screening decision quality, screening completion among those patients who made the decision to screen. Do they actually follow through with it? And then stage of readiness for smoking cessation among individuals who currently smoke. And to be honest, we had to add C in because, study sections don't seem to think decision outcomes are sexy. And so we had to add a behavioral thing in there to, and the resubmission to get this funded. And then AIM-2 and AIM-3 just break down the clinician factors versus the patient factors that predict those three things. We're currently analyzing the data from the clinician sample. We were really lucky right before COVID hit. We actually started recruitment in November, December of 2019 of our clinician sample. We had a clinician champion. The medical director sent out an email prior to us recruiting, saying, hey, this is coming, this is voluntary, but this is an important, this is a topic that KP is interested in and important to us. We did offer us incentive as well. So we actually, I was shocked, we actually recruited our, I think our goal was 125 and we enrolled 137 providers right before the first of the year. And so we had our sample before COVID hit. Our patient sample, well, we're recruiting more, but it's actually going really well. COVID stopped us for like 2 months because nobody was having primary care visits. But then when they started back, we've actually been pretty good. We're on track to finish up recruitment in the time span that we had allotted on our study timeline. This is just my references from that particular study. And I think I left enough time for questions.
Thank you very much, Dr. Carter-Harris. We have one question in the chat that I wanted to pass along, and then James also has a follow-up that he wants to ask verbally. But the first question is from Aaron Hirsch. Does physician recommendation for screening assume patients are familiar and comfortable with a paternalistic healthcare approach?
Do you mean the fact that physician recommendation is the statistically significant variable? Does it make the assumption that they're familiar and comfortable with paternalism?
I think that's what she was alluding to, the fact that the effect size of that relationship was outweighed virtually everything, any of the other contributing factors.
Yes, it does. And I agree. Yes, and this is very similar in other types of cancer screening like colon and breast, that physician recommendation does make, is associated with screening completion, but it is a paternalistic healthcare approach. And some, it's in our current study, we're actually measuring control preference so that we can understand if people, like to make the decision themselves and gather all that information versus a shared decision, versus some people will they'll look at you and say, you went to school for that long. Why I want you to make the decision. People have different preferences, but is there?
So the follow-up to that one, and then I'll let James pose his question, was about self-efficacy. But I wanted to ask you, what exactly self-efficacy did you measure? Was it self-efficacy to have a lung cancer screening exam, to navigate that process, or what exactly was the self-efficacy tied to that you were measuring in your study?
So we were measuring the self-efficacy for lung cancer screening. And that encompassed the entire thing, like making the appointment, getting to the appointment, getting all of their questions answered. And I know, Jamie, you were just asking this so that you're figuring other people had that question, because you were actually one of my content experts for the lung cancer screening health belief scales. And but that was not clear. But yes, it was the entire process. It's a 9-item survey item that it's a 9-item survey that looks at all the different components of going through with a lung scan. But it also includes questions like, I feel confident that I could complete a lung scan even if I'm worried about the results, and questions like that.
James?
Sure. For first, great talk. That was really exciting, and I love the golden doodle. I don't know if you've talked to Kathy, but I think Kathy either has a golden doodle or something pretty similar to what you have, but very adorable. So my question relates to, that people can express fatalism in terms of like, why should I bother? And at what point is that essentially justified? Obviously if we knew someone was 3 months away from dying from something else, there'd be no reason to follow up on a detected, relatively early stage adenocarcinoma. Of course, we don't always know that, but at what point do certain comorbidities, lung function, heart function and so forth, sort of modulate that decision and saying, you should probably worry about these other things because they are the greater risk right now. And finding an early stage adenocarcinoma is probably just going to create more fear and intervention than you need right now. And I don't know if there's a way of magically knowing that.
I don't think there's a way to magically know that. But I agree with you. I think that it's something, that's why this is such a complex decision that needs to be done between the clinician and the individual. It was funny. I was telling Jamie, I taped a podcast yesterday, and it was on the new lung screening. Oh, somebody has a mini burn. Oh, sorry. Coming. Okay. We need pictures. The host of the show, because I made the comment that I said also in this presentation, that the decision to screen or not screen is equal in my mind. And he thought that was very perplexing. So then I explained to him, I said, some people are not a candidate for the surgical intervention or the treatment. So then if a person has end-stage COPD and they couldn't undergo this surgery, then why would you put them through that? And so he couldn't wrap his mind around why would you say, give someone all this information and have this test out there, but then not do it? Because there's reasons that are very specific to the person's medical history and what you're talking about, why the individual might not go through that. I mean, you wouldn't want to put them through that and then have the fear of like what I'm going to go through, or the fact that you can't do the treatment. And so that's why I think it's so important that an individual who's eligible for lung cancer screening not only knows that this exists, but has the opportunity to have a discussion with an informed clinician, help them weigh that decision. And then we need to respect it as the clinic. Mass screening is not the goal in lung cancer screening, at least in my viewpoint. And I think Jamie thinks the same thing, but I do not view it as, and I don't want to put a scanner in like TSA and have people going through get scanned without being informed, because it's not the right choice for everyone.
Very good points. Thanks.
So, Lisa, your model that have developed and tested has been really about so far about initiation of screening or initial uptake. There was a little piece on maintenance, but I wonder what you have either learned about sustainment or efforts to continue and adhere to the lung cancer screening algorithm that has been informed by your model.
Yeah, so yes, thank you for that question. I think early on, of course, there were so many people that didn't know lung cancer screening existed. Just getting to the point of initiation was important. But also, when you are initiating when you are initiating a lung cancer screening program, it's really important for people to understand it's a program, and that it's not just a one and done. That if there's something that's abnormal, that we need to adhere to follow up, that the possibility of things being abnormal, and adherence to an annual screening regimen until you either age out or pack your history out of the criteria. That being said, we have Karen Mornley, who's a cancer epidemiologist at KP Washington. I'm a co-investigator on her study, and she's using my model. Her study is actually looking specifically at adherence to annual screening recommendations, looking down the line of that. So I'll be interested, and we're actually revising the lung cancer screening health belief scales to be more specific to adherence to annual maintenance as opposed to initiation. Does that make sense?
So next question, Hillary.
Thanks for this great talk. This work is really impressive. I'm a geriatrician and exploring Alzheimer's within brain function, as James was talking about it, if it's heart function or another function, but what about brain function changing and affecting the experience of the person and their dyad. So I wonder, in your data or data that you're aware of, are you screening out individuals with cognitive impairment so that you know that they have capacity to make their decision? And then also, could you comment on whether your instrument, among those 9 items, I'm not familiar with your instrument, are there particular items that focus in on the thinking aspect of that ability to get lung cancer screening done?
Of the what? The thinking aspect?
Yeah, I guess, not necessarily the logistics, like ability to go through the scan, but more the decision in particular.
Yes. So there is an item that talks about the feeling comfortable obtaining the information they need to make a decision. It's not like it's not worded cognition, but we're really trying to tap into they feel confident that they have the means to get that information from either their doctor or somewhere else to make the decision. The other thing that you mentioned about geriatrics and potential cognitive decline that could affect their decision, I think that's, I haven't personally done work on that, but I think that's, I think that's massively important, regardless of whether you're thinking about lung screening or PSA or any of these preventive screenings, as well as treatment decisions, because, when someone has a cognitive decline, how do you know that they have the capability to make that decision a good decision? And are you involving a caregiver? Do you have the caregiver and patient dyad? My father had advanced dementia and passed 8 years ago, but early on in his Alzheimer's dementia, he compensated really well. We didn't know. And so if someone is compensating, could they be making decisions about something that aren't necessarily the right decision for them if they had full faculties? And then how do you bring and when do you bring that caregiver in? Because you also have to respect the fact that this is the patient and their autonomy. That could be a whole program of research, Hillary.
Well, and with collaborators like you, and certainly definitely remember the NIA Alzheimer's supplement. So the fact that you have your, funded grant, you could certainly supplement to ask an Alzheimer's or cognitive impairment specific question, because you have like a huge sample.
That's really interesting. Okay.
Any final questions from anyone else out there? Well, thank you everyone for attending, and thank you, Lisa, for your comments today, and your presentation is really wonderful, and appreciate how much depth you bring to understanding these choices, the complicated choices about lung cancer screening. I just have a couple of announcements that I want to share before wrapping up. One is a reminder that I'm going to be sending you an email about suggestions for speakers for next year, and the best news just in is that Dr. Linda Cook, formerly of the University of New Mexico, has agreed to take over the Associate Director of Cancer Prevention Control Population Science at the University of Colorado. So Kathy actually forwarded that during the presentation. We are incredibly excited about this transition, or this opportunity to have Dr. Cook here with us in Colorado very soon. So please feel free to pat Kathy Bradley on the back for this. She's done a ton of work to make this possible, as well as the rest of the leadership, including James and really everyone, and Rich and the whole team. So it's great news for us here in Colorado. So with that great news, I'll wrap up and thank everyone again. And remember, we'll be back next month.